Good afternoon. This is the House Appropriations Committee. It is still Tuesday, December 16th, 2025. It's 3 o'clock, and we have our last couple of Human Services departments to come and talk to us about the budget adjustment. So first up, we have the Vermont Department of Health, and we have a new commissioner. Welcome. We'll introduce ourselves. So we have to practice that. We haven't done that today. And from the finance director as well. So if you two would like to introduce yourselves, then we'll let you know who we all are.
Sure. I'm Rick Hildebrand. I'm the new commissioner of the Department of Health.
And I'm Megan Hook. I'm a financial director at the Department of Health.
Great.
All right. Welcome. I'm Dave Iacovoni from the Lamoille, Washington district.
And John Kosenska from Burke, and I represent 10 towns in the Essex Caledonia district.
Tom Stevens from Waterbury, represent the Washington Chittenden district, which is made up of Waterbury, Bolton, Huntington, and Buell's Court.
I'm Marty Feltus from Caledonia 3, which is Linden, Sutton, New York, Sheffield, and Sutton. I forgot somebody.
That's right.
There's a map attached. I am Robin Shine. I'm from Middlebury.
I'm Wayne LaRush. I represent Highgate, Franklin, Berkshire, and Richford.
Hi, welcome. I'm Mike Murwicki, and I am from the southeast part of Vermont in Windham County, and I represent the Windham 4 district. That's Putney and Dummerston.
And I'm Lynn Dickinson. I represent 2/3 of St. Albans Town.
Me, John.
So welcome and take it away. I think we have copies and you're going to screen share. So that's terrific.
Right. And the meat of this is pretty short, so I figured I'd take this opportunity to tell you a little bit about myself, my background, and some priorities that we have in the health department that might be helpful. Other legislators have found that helpful in the past. So my name is Rick Hildebrand. I am an internal medicine trained hospitalist, so a doctor that treats patients in the hospital, sick enough to go past the ER, but not quite so sick in the ICU. Okay, and that's sort of where my folks typically land. I've been in Rutland for almost 14 years now, following my residency training over at Dartmouth. And when I started in hospital medicine, I thought I was going to be a clinician at a community hospital my whole life. When I was doing my training in Dartmouth, I liked the Vermont side of that equation more than the New Hampshire side. And I knew
it is Vermont.
Yeah. And, I knew I wanted to do community medicine. So I ended up at the largest community hospital in Vermont. Anyway, when I started, there was a couple of things that became immediately apparent to me. One is that I can't fix the problems of my patients within the 4 walls of the hospital. The problems are too big and they're beyond the care that I can deliver there. And that led me to reach out to the community partners that I had around me, to the FQHC, to the VNAs, to the nursing facilities, and an organization that ended up becoming something called the Rutland Community Collaborative to try and improve care, reduce readmission rates, which is something that we care a lot about in hospital medicine, and reduce admissions to the hospital in its totality. And it was great work. It was really engaging. We did a lot of work and we made a difference in that community in those measures. But even with that work and with a lot of stakeholders, the problems were still there. And it really was more about social drivers of health in many regards than it was about any medical problem that we were treating. Lack of access to finances or transportation, nutritious foods, exercise, you name it, the problems were significant. Substance use disorder, mental health disorders were paramount. My wife is a LICSW, she's a social worker. She works down at a therapeutic farm work program down in Shrewsbury. Anyway, so that led me to sort of pursue some other endeavors outside of the hospital, some boards and commissions. I was on the board of one of the DAs. I joined the board of medical practice 6 years ago. I served as their chair for 4 years, and tried to sort of get involved more in population health and things that are really more outside of what I was doing in my day-to-day, which at the time was something called being a chief medical information officer. I found myself in hospital leadership over the course of my career. I was a hospital executive for a while, but I cared for sort of the interface between IT and medicine, which is an interesting space, but not really my passion. Anyway, was very involved in the COVID response at the hospitals, the COVID czar, and I ended up chairing the infection control committee. And I had said to myself for some time, if and when Mark decides to retire, I might throw my hat in the ring. And after many months of interviews, found myself at the health department. It's been a wild ride since I've been here. And I'll tell you, there's some things that are very clear. It's an amazing group of people that work at the health department. They're incredibly intelligent and care a whole heck of a lot about Vermonters and the health of this state. That came through in bounds and was frankly shocking to me how excellent the people were that I was working with. And I'm still learning a whole lot. And I have a lot of questions and not a whole lot of answers, unfortunately, but I know I've got the right team around. So as a reminder, this is our vision and our mission and the values for the health department. So our vision is that all people and communities in Vermont have equitable opportunities to achieve the highest level of health and well-being. Our mission is to promote the physical, mental, and social well-being of people in Vermont by advancing equity, protecting against disease and injury, and preparing for health emergencies. And then our values include equity, collaboration, inclusion, harmony, and safeguard. So sometimes it's challenging to explain exactly what the health department does or what public health actually even is. And we've used this framework of detect, connect, prevent, and respond, which can be a useful framework to help understand what public health means on a broader level. As an example, relatively recently, we detected a number of cases of pertussis, which is also called whooping cough, in a school in Washington County. We responded by providing the school community with resources on how to protect themselves and their families, alerted the healthcare providers in the area to help prevent the spread and ensure that people had access to vaccination, which this is something that can be vaccinated against if they were under vaccinated or unvaccinated. Our work goes much far beyond infectious diseases. We have worked with school liaisons. We work with our local health offices to improve school health. We collaborate with partners in maternal health. We connect with Vermonters with cooling sites during hot seasons. We help with health-related behaviors. We help with smoking cessation, manage pain and other long-term health problems. There's so many tendrils that the health department has in so many areas. And it's taken me, frankly, a bit of time to get my arms around everything that we do. This is our organizational structure, which I have referenced this many times just to remind myself of all these little chiclets and where they go. That's what we call them. Yeah. The Department of Health has about 600 positions, depending on how many open we have at any given time. And we have a central office and 12 district offices. It ranges from very, very concrete clinical work, like the Office of the Chief Medical Examiner, to much more, or home nursing visits and laboratory testing and other things that are very concrete and clinical, to areas that are much less clinical, like community-based work on disease prevention, health promotion, environmental health, looking at water quality, air quality, and food safety. And we have experts in all of these areas that know far more than I do. And if there's a specific question that anyone ever has in an area, I will not hesitate to call on them to give you the actual answer. I'm happy to be a pretty face and talk about it, but really you want to talk to the experts a lot of times. So it's an interesting time I have found myself in public health. And to be fair, this was intentional. I very much, part of the reason I am here is because I felt a calling. There is an attack on public health across the country. And it's very clear to me that one of my main directives is to preserve the trust in public health. We are lucky in Vermont. There's a high degree of respect of the health department. That is not true across the country. And I've talked to some of my colleagues across the country, and they did not get out of COVID unscathed. There is a ton of turmoil nationally. There's a lot of uncertainty, and that seems to be amplifying every week. We need to be the rock that people can rely on. We need to preserve that trust that people have in public health. Because without that, it's very, very challenging to do this work. The good news is we have a lot of trusted names and faces. We are in local communities. People are embedded in the hospitals, in their health systems, and they are known entities, and they're helpful in many, many regards. So that's really a strength that we have. There are, however, a number of issues that we are likely to encounter over the course of the year. There's a lot of false claims and falsehoods that we've heard on the national level that has led to uncertainty at the CDC and other historically trusted institutions. I have been working with our team at VDH to ensure that both in the press and in other areas, we are reaching Vermonters to ensure that they have the accurate information that they need, that they know who to connect with. The drum I have been continually beating is to please talk to your trusted healthcare providers rather than listening to news articles about, health and health-related information. We've been working with a large number of stakeholders across state government to ensure people have access to care and immunizations, including through the Department of Vermont Health Access, OPR, Department of Financial Regulation, Health, and so many more. And we are working with a bipartisan group of legislators to ensure that we have access to vaccines within our state, and that regardless of what changes that happen at the national level, people remain informed and have access to the right vaccines that they need.
Yeah, but
Yes, of course.
Thanks for coming.
That's okay.
I think Vermont has done pretty well with vaccination rates. But for instance, I think South Carolina right now is seeing a measles outbreak, and there was one in Texas. Where are we at with the levels we need to maintain herd immunization?
Yeah, for measles specifically.
Well, in general, I mean,
Yeah.
big question, I
yeah.
guess, but
Yeah, and it depends on the specific disease, right? So depending on how contagious an illness is, the percentage of people that need to be vaccinated to maintain herd immunity is different. Measles is the hardest one because it is so contagious that if you don't have vaccination rates in the high 90s, you can lose herd immunity. Okay. Other illnesses are less contagious, so you can still get herd immunity with lower levels of immunity. Whooping cough, like we talked about before, you may see a small dust up, small number of cases, but it's not going to spread in a broader context because we have a high vaccination rate that's above that threshold. So it really is dependent on the specific disease that you're looking at. All that said, right, we are keeping a very close eye on vaccination rates because we are concerned that we might be seeing some slipping in things like COVID and flu vaccines. Okay, and that's just a marker of, hey, where are we with vaccinations in general? Something we keep a very close eye on and make sure that if there's changes, we can provide information to people as they need it, connect them to the right resources that they need. Okay.
thanks.
You got it. As it pertains to the immunization work, just to be clear, we're not looking for funding. This isn't a funding issue. We just want to make sure people have access to the right information. So we're going to be proposing some legislation just to ensure that that remains the case. So another obviously big topic, if you haven't heard this already, I'm sure you will, is around substance use disorder. It's clearly a big priority of mine and the Department of Health. We do a number of things in substance use disorder, including prevention, treatment, and recovery. Okay, recovery is the area that I've probably spent the most of my time in the recent months. This is a landscape that's continually changing. For many years, for at least 10 years, we've been focusing mostly on opiates. And opiates remains the number one problem with substance use disorder. But that landscape is evolving. We're seeing more and more stimulant use across our state. Stimulants are a different game. Of the stimulants, meth is the worst drug that probably mankind has ever made. And my colleagues across the country who have populations where meth use is much higher, the stories they tell me are harrowing. I mean, these people can become quite violent and aggressive with this medication. It's very hard to treat. Recovery is measured in many, I mean, it's measured in years for opiates, but it's even longer for methamphetamines. It's not at a very high rate in Vermont right now, but it is on the rise, and we are seeing more cocaine and polysubstance use as well. The treatments are different. There's not MAT or MOUD for stimulants. Okay, so this is going to be an ever evolving field and something that I need to be on top of with my team for sure. And it's, again, just something that you all need to be aware of and how that's changing.
We have a question, I think.
Yes, of course.
In the past, I've been critical that, back in the sixties, we had a tremendous don't smoke campaign. or something.
Yeah.
And I've been critical that I don't see the same kind of campaign coming out of the health department. I see more, other kind of messages. And when I asked that question before, they said, well, you're just not looking in the right place. You're too old. That's right. But I don't think that was a good reply because I think everybody should be seeing that message.
So you're absolutely right. And there's, I think, two things in there. One, we need to be better about communicating the work that we're doing. That came to me pretty clear. We're doing a lot of work in substance use disorder. Just today, we're opening, we're not, the Valley Vista is opening a facility, a 30-bed facility, which there was people who were not aware of the work that had gone into this that should have been aware because frankly, we haven't done a good enough job communicating it. So the number one, yes, you're right. You as legislators should absolutely know what we're doing, okay, in substance use disorder and prevention. And B, you're right. Prevention is far more effective than, well, I don't know if it's more effective. It's more important than treatment, right? We want to try and prevent this illness from happening to begin with. Prevention is an incredibly important piece of work that we do. And I do want to connect with you all more about what we are doing in prevention and how we can show the data and the outcomes related to that, okay?
Thanks.
All right. Go on to access. So this is the last area that is something that is important to me because of my background, but it's also important to public health. We have been talking about healthcare transformation as long as I have been in the state, and those of you who have been in the state longer, I'm sure, have been talking about it for 10 years before I was here. We have an opportunity now to look at how we are delivering healthcare across the state. However, I want to make sure that we maintain access to care regardless of what work we're doing, okay? Obstetric care is incredibly important in every community in Vermont. And we need to make sure that we don't have people with excessive drive times can receive the care, both prenatal and postnatal care that they need, regardless of the finances. And I want to try and help in whatever way I can. Health department wants to help. This is not something we own in isolation. This is something that is shared by many state agencies. But if there's ways in which we can help with either data or other ways, we want to do that. Transportation is incredibly important. As we talk about regionalization of healthcare services, to do that effectively, we need to have good electronic systems of information sharing. We need to have great transportation. We don't have either of those right now. Transportation is primarily delivered by the EMS system, something that we have a piece of within the Department of Health. I've talked with our EMS services division, and they're very interested in being part of the solution here. There's barriers that we have to talk about in terms of funding and some regulatory, changes we might need to make, but I think there's a opportunity in the transportation realm. And then reproductive health care is another real concern that I have. We want to ensure that we have access to these critical services, regardless of any federal changes that come down the pipe. This is a really, really complex space. And there are a lot of people that are involved in this work that probably can give you more information than I can. I just know it's really important to stick the landing. We can't, while we're going through transformation, end up having gaps in coverage because that's what people get hurt.
So we have a question. I'm going to interrupt you guys.
That's fine.
Thanks for being here today.
Absolutely.
Good to meet you. So I just had a recent conversation with our local EMS service, rescue. Calix is in the St. Johnsbury area there. We're just kind of talking about some of the things coming up for them, and just like our hospitals are having difficulty with balancing their budgets with reimbursement rates, so are the EMS folks here. Again, it's all about the demographics, to some larger degree here. I know there's this regionalization conversation planning going on here with that, and I'd just like to hear a little bit more about I know you're just into the seat here of things, but what your thoughts are about the regionalization of EMS service, how that might play out, especially in our more rural areas. We have a lot of territory to cover, and some of our services are covering 9 to 11 towns.
Right. And I think if you talk to the EMS services, they'll tell you they're strapped. And the system that they've had that has worked effectively for some period of time, to some extent, is really almost at a tipping point of not working very well, okay? They only get, I don't know if you know this or others don't, they only get paid if they transport someone to the hospital. That is the only source of revenue for most EMSs.
I know.
That's a problem, right? Because we ask them to do a lot more than that, and we want them to do more than that. We want, the concept of community paramedicine, I think, is an opportunity not only for revenue, but also for decreasing healthcare costs by avoiding some transports to the ED and other things of that nature. The transportation itself, that should be reimbursed, and we need to figure some of those things out. This isn't something that the state should be funding. It's something we need to figure out with our insurance partners around payment for it, right? But they need an infusion of capital through services other than what they've been doing, in my assessment, to continue this system, because it's really teetering on the brink. There is a structural issue, and I think many of our EMS folks will tell you that there's a lot of independent systems that have been designed effectively to provide emergency care and transport people to the hospital. When we're talking about care delivery or transportation, there needs to be a superordinate sort of way to organize that. I don't know what that looks like. I know that the folks who are in the EMS can probably give me the answers of what that looks like, but we should engage in the conversation about, hey, how can we restructure the EMS system to better serve the needs of Vermonters? Okay, and these are going to be hard conversations because
Yeah, for
it's
sure.
changed.
If they're come to a position, you do a transfer that takes them out of their community here. And some of those transfers are quite lengthy. You know that.
Right.
And if they're going to Dartmouth from St. John's, bring it back. It's a chunk of time.
And what is frustrating to me is there's one, down in Rutland, Regional will take someone to Dartmouth and then have an empty bus come back to Rutland when there was a person that needed to go from Dartmouth, one town over, and we're not coordinated, right? So we need to have that information system to allow for coordination of some of those services, not so much wasteful time.
So it'd be great to hear more about that as that kind of develops.
Absolutely.
But this coming year would be great.
Wayne
Absolutely.
has a question, so.
So, we've been aware that some of our emergency rooms have been really overcrowded. So if they have to transport to a hospital, does that contribute in any way to that overcrowding?
So crowding is an interesting problem that, my lens is that of the person who's admitting to the hospital, not of the guy who's caring for them in the ER, but many of my patients will board in an ER overnight, okay? It's a really complicated problem. There's not one thing about it. Transportation is a piece of it, right? So if you don't have the ability to transport a patient who needs to go to a different facility, they could end up staying in your bed for longer than one would need. The other problem, though, is around non-medical care, non-hospital level of care, right? So a lot of times when you look at crowding, the actual problem is more around capacity within the inpatient unit, which has to do with capacity in the sort of subacute units, right? So sometimes it's a really complicated problem around sort of borders in the ER, if you will, which is what they're termed. Transportation is a piece of that, but it's a really complicated.
Yeah, it's probably maybe just a small piece, but I was wondering if some were being transported and had to be dealt with at the hospital that didn't actually need to.
Correct, right. So community paramedicine, the idea that we can treat someone, urgent care is another option, right? Where people go to an urgent care center as opposed to an ER. Well, what if we can treat someone in their home with a paramedic rather than having to send them anywhere and having them still get paid to do that? Because currently, if they do that, they're not getting paid, right? So you're absolutely right. That is
Maybe a small part of the problem, but it could be.
Oh, for sure.
But lots of little things make a big difference.
Exactly.
They really can, yeah. Okay, thanks.
All right. So again, the last piece that I was going to touch on was reproductive health care. Important. It's protected by our Constitution. Decisions around reproductive health care should always be made between patients and their providers. And our BAA asks to change some funding streams to ensure we continue to have access to these critical services, again, regardless of what happens on a national level. I'm going to turn it over to Megan to take it from here.
Yeah. So our 26 budget adjustment is rather brief. If you're looking at the AHS ups and downs, I believe it's on page 9, but these are really our two items of substance here. The first in our admin and support appropriation, we just have a transfer from the agency central office for that agency of digital services service level agreement that, yep.
At neutral to the agency, but another one that they moved out.
Yep. Costs are moving from AHS to us. And then what the commissioner was just speaking of, in our public health appropriation, we are asking for a swap of what was funded with investment global commitment dollars to be funded by general fund for a grant to Planned Parenthood of Northern New England for family planning services. And those are funds that I think Secretary Samuelson mentioned in her testimony, but because of the passage of HR1, those costs, there's a pause on Medicaid funding to Planned Parenthood. So we are asking to allow that, to have this swap in funding source so that grant can continue and we can continue serving those patients. And that is.
Yes, I can see a short and sweet.
Yeah.
You may not be the right person, but if you could help me. I had a constituent ask me how much primary care Planned Parenthood provides.
Okay.
I've been trying to find it without much luck. Last year, I thought I recalled the testimony that it was rather significant that, anyways. You think, is there someone at your shop who would know that or?
We could definitely follow up and we might have to reach out to other areas of
Yeah.
the agency as well, because
Would you-
we're not the only ones who provide funding, but it looks, we've got they serve about 16,000 Vermonters. So, but I'm not sure what of that is primary care versus,
If you can get someone to define primary care for me, then we can give you an answer, because I'll tell
Well,
you.
they're given codes, right? That you know-
If they have that information, or somebody in the room here may have information and can get it to us. It's a high amount.
That's what we were told.
Yeah.
Right.
A lot of OB care in general, a lot of OBGYNs provide primary care to a large percentage of folks. So it's, yeah, a chunk of what is being delivered there is, it's usually.
Thank you for any help you might be able to give me on it. Thank you.
So that's your presentation.
Very nice.
Great.
Thank you.
Well, we really appreciate it.
Very informative.
Thank you for coming in. Nice to meet you. Welcome.
Thank you. Thank you.
When did you start?
So this is about 2 months ago. This is the beginning of.
Okay, you're almost,
Great.
yeah.
Thank you very much.
Maybe till January. Anyway, thank you. We'll be seeing you again for the budget, and we'll look forward to that presentation too. This is a great start, so.
Thank you.
Here, appreciate it.
Bye now.
One more committee for today, and that is DEVA. Department of Vermont Health Access. And I did see Stephanie, so I know she's around. She's here too. She's here too. Good.
Hi, Stephanie. How are you?
Hey, thanks. How are you?
Good to see you. Hi, Deshaun. You.
Last time seeing Stephanie, unless we get her back before her next move. I'll let her tell you.
Okay. Changes in this committee too.
I'm already back.
Good to see you again, Stephanie. Haven't done it a lot better.
So if you want to introduce yourselves for the record and then we'll.
I'm Sean Groves. I'm the Commissioner for the Department of Vermont Health Access.
I'm Stephanie Barrett. I'm the Financial Director for the Department of Vermont Health Access.
The end of January.
Until the end of January, when I'm retiring from the state, but not from work. I'm gonna go work for the town of Randolph for the last working years of my career.
I'll be lucky to have you, Stephanie.
Yes, they will.
How would you like us to start? We have a PowerPoint that is the high level summary of our ups and downs.
Yeah, well, why don't we go through this? We have an hour. That's Eva. Dave, is that you?
I think I do. I do, yeah.
Whatever you had last year, you still have it. So why don't we go through this and then we'll talk about what you know, are the details of what your asks are in here as well, or they're?
So the details are in a summarized fashion in this, and then the very granular line item details are in the ups and downs, and we can switch to that at any time.
Okay, well, let's start with the overview part. Let's
Okay.
start with that, thanks.
So we'll go through the DIVA admin budget, which is very different than the DIVA program budget, in scale and what it pays for. Admin keeps the lights on, pays the people, pays the contracts, and program is primarily all the services that we pay providers for. Most of that money flows through the MMIS system with our fiscal agent. And then we have a few one-time requests in the BAA for general fund funding. And then we thought we'd just update you on a few of the one-time items that you appropriated last year and what the status of those are. So in the DIVA admin budget, there's no real adjustment to the staffing at all. But we do have many contracts that are held by DIVA, and several of those have adjustments mid-year, amendments that have come up since the budget was passed, et cetera. We have a couple small adjustments to a couple contracts that support our chief medical officer. We have a person that's been on contract for several years, and then we have another person, another physician that focuses on mental health. And that's what that $39,000 gross adjustment is. This is probably the right time to remember that in Medicaid, which is the majority of DIVA, things are both in a gross dollar amount, and then we also note the general fund amount, because Medicaid is a matched program, where it's state and federal dollars together. So the gross dollar is the total cost. And then the general fund is the general fund portion of that, the state fund portion of that. So where your tightness and rub is on the on the general fund and state funding. And then we also have amendments that have happened in our Gainwell contract, which is a big contract that runs the whole Medicaid program in terms of the claims processing and the payments out, not just for DIVA, but for the other parts of state government that have payments flowing through that system and out to the providers. That in total is just a smidge under $2 million. In terms of the state match, it's about 10% of that, because the majority of this is a development and implementation funding. So the majority of this cost is on the ad hoc, what we call DDI, and that gets a 10% match under our agreements with the federal government. So any questions on the DIVA held contracts part of our picture? Also in our budget, in our operating budget, are contracts that aren't held by DIVA. They're held by ADS. They're technology contracts, but we are the payer of those contracts at the moment. And so we get the invoices sent to us and we pay them. And there are some adjustments to those DIVA held contracts. The biggest one is in our what's called MDWAS, our Medicaid Data Warehouse and Analytics Solution. I don't know if folks remember, but 3-4 years ago, you provided one-time funding to develop this system, and it is turning on. It's been going through testing as we speak. And as we head into January, we move to another phase of this, which is the maintenance and operations phase. So the one-time money was for the development of the system, and now we have to maintain and operate the system. And that comes with a price tag that is now coming into our budget mid-year. So you'll see this again when you see the 2027 budget in front of you for the full year as well. So that's the single biggest admin adjustment in our budget. And then also over in ADS, they have a smaller Gainwell contract, but they also pay for the licenses for Oracle that supports the Vermont Health Connect, and those licenses are going up. And there's been a small adjustment to the Gainwell contract in ADS. So that's the final adjustment in our contract world. And then in terms of regular operating expenses, the primary adjustment here is with the return to office, what we call RTO, the 3-day standard back in the office. DEVA is one of the entities that's moving to lease space in February timeframe. And so those leases have now been executed. They are now going to be paid for out of our budget. And so this is the partial year cost of the leases for DEVA.
Annual, it's around 360,000.
I think it's 400 something annualized, because this is a 7-month
Okay, it's not a full.
amount. So the 252 is the total amount. We match this at the admin match that we can because we're a mix of all sorts of types of
Yeah.
matching percentages in DEVA.
I was looking just at the general fund, not the whole.
Okay. Yeah.
Thing. The whole thing sounds like it's close to $1 million.
The DEVA portion is 400 and something. I can get you the annualized number. You will see that in the 27 budget. And then just as you just heard from the health department, there's a couple other adjustments. A net neutral agency-wide adjustment related to the service level agreements for the Agency of Digital Services. That's, you see that as an up in our budget, but it's not an up in total. And then also with Planned Parenthood of New England, we're doing the same because of the restriction, the 1-year restriction of funding for Planned Parenthood in the HR 1 bill, swapping out the funding source. So we're keeping the budget whole for what is in our budget for Planned Parenthood, but we are substituting the federal share that was embedded in our budget for general fund for the budget adjustment. So it reflects a full year cost of doing that because HR 1 was passed in early July. And you'll see this in our program budget as well. So before we move to our program budget, does anyone have any questions on our admin budget? So when you're looking at the ups and downs, the program budgets across 3 appropriations, one is very large, the global commitment appropriation. What this presentation will do is walk you through all the pieces together, but we can stop at any time if you want to break down into anything more granular. And we understand from folks that have been before you earlier today that you'll probably have some questions on our consensus update, which is the process by which the Medicaid program budget in DEVA is updated year to year. And that's with staff from DEVA, staff from the central office, staff from joint fiscal, and staff from finance and management come together and look at the data midway through the year, update the estimates for caseload and the estimate of cost per case. And so this is a substantial $33 million up. In terms of a percentage, it's not very substantial, but it's a substantial chunk of funding up across all our caseload and utilization needs based on how, because last year when we built the budget, we were building it at this time. Folks, I don't know if Dave, Representative Iacoboni, or folks look at the dashboard that we put out monthly. But as we went through the end of the year, you could see that when we were closing out 25, that there was a gap growing. We were able to close that gap with help. And then this is updating with new information on what actual costs were through the first quarter of the year, what we're seeing for trends. And so that's what's driving these numbers. And the caseload continues to go down, but the cost per case is staying up. So that's telling us that the more expensive folks are the ones that are staying on the program as the caseload comes down. And we just can't, we didn't quite get it right last year. We didn't quite get it right coming into building the budget, in terms of where that trend of cost per case is up. Some of the things that are driving that are our pharmacy costs, because our net pharmacy cost is coming up. Our rebates are a little bit lower as a percentage, and it's a very large chunk of our cost. So that's what we're seeing. We're not actuaries. We're not going in and building a big model of every life in the system. We are looking basically at average cost by Medicaid eligibility group at points in time and saying, is it holding steady to what we thought it was going to be? And while the caseload we get pretty spot on, we can see it continue to go down. It's actually that cost per case that comes up. It has been
cases.
we see a little bit of that in some places, but on average across, it's just a higher cost per case, which tells us that we do have, as the folks that are coming off in terms of, total coming down, what is the health status, the utilization of those remaining people are at the higher end, and we're not capturing that every time we come in to build that consensus. We do, we add an acuity factor. It just hasn't been sufficient to capture where we end up when 6 months and then 12 months further down the road, in terms of the cost of covering the folks that are enrolled in Medicaid and paid for by DIVA. I did understand that the committee had a specific question about demographics. And we're going to take a look at that because actually 2 years ago, we started collecting like for each one of our Medicaid eligibility groups, we have caseload information every month. And we started collecting starting in January 2024, just the distribution of age in every single one of those Medicaid eligibility groups to see if it was going to change over time. And now we're almost 2 years into that. So we can actually do some analysis and see if the average or the median age has come up, if the distribution of age in any Medicaid category is coming up. And that might be a little bit illuminating to the pressure that we're seeing on the cost per case.
That's great. And I think we'd be very interested in seeing that when you have it.
Yeah, I was like, that's a good question. This committee said.
You're right on it.
Right.
And so my team is going to look at it.
That's good.
But that caseload and utilization, that consensus update, every once in a while it goes in the better direction for us. But for the past few years, we've been struggling. It's always, as we've come out of the unwinding of the pandemic, we expected the caseload to come down and we expected the cost per case to go up. It's just that the trajectory of that cost per case is sharper than what we expected, but we're not analyzing. We're not alone. I sit in on the NAMD financial directors affinity group calls every so often, and other states are still struggling with it. The same outcome, that there's just more pressure on the cost per case.
Do you have a question, Mike?
Yeah, so in those analyses, where within the cost per case, the upward pressure, is it specifically in certain areas or across the board in different aspects of cost per care?
Well, we know one is the pharmacy costs are part of it, but every Medicaid eligibility group, we're looking at the average for each group. And so there's not, sometimes in the age of the blind and disabled children, you can really see that you have an unusual number of very high cost cases. Right. But with the other Medicaid eligibility groups, it's a wide range and we're looking at it basically on just an average point in time.
So if you do analysis like a graphical analysis of that sort of thing, you got some noise in the system because you can't predict how many blind children may come in. So that's probably not.
That's a very small group. What you can't predict is as your caseload is changing downward, if you're working on an average, are you making enough of an adjustment for the lower utilization of folks that are leaving versus the higher utilization of folks that are staying? And we can see it very clearly after the fact, like any,
With the trend line, you might be able to get a trend line, but then
Yeah.
something's still changing.
Yeah.
And the trend line may not be predictive.
And it's, the last time we went through this, about 9-10 years ago, the trend lines were, that's one of the things we looked at initially. Those were the trajectories were flatter.
Dave, sorry.
Good question. You mentioned the caseload increase that the percent was rather small. When you get a minute, could you let us know what the percentage changes? Thank you. Let Nola know and let us know. And does the FFP rate ever change mid-year?
No, it gets set every year. And so it changes with
Their
every
fiscal year, right?
federal fiscal year. Yeah.
Yeah, so that'll be part of the 27. presentation.
Yeah.
Yeah. We don't know
Yeah.
what it is yet for next year.
We do.
We do.
Yeah.
Is it good for us or bad or?
I think it went,
Pardon?
it went, and I'm looking at, I think it's a pressure on the budget
Yeah.
coming into 27, significant
Alright.
pressure on the budget.
Thank
coming
you.
into 27. Another adjustment that's happening mid-year is in our applied behavioral analysis benefit, which is mostly treating autism spectrum folks. An adjustment there in making sure that our coding is correct. And this is a downward adjustment, and you also see this when you see the 27 budget. That's why it's negative in red. It's actually correcting the coding so we are properly, matching up the policy and the payment here. But the size of this in terms of the benefit would be felt by the providers for this, but that's an internal policy alignment and making sure that we are following that. And I just wanted to acknowledge that for the committee. This is familiar. The next one's familiar. Every year, the federal government has an update to what's called the Medical Economic Index. And that is the index that's used to adjust the rates for the FQHCs and the rural health clinics. And so what you're seeing is a partial year adjustment for those rates going up based on that index. And then you'll see that annualized when you see the 27 budget. And then the other notation here, we've already talked about a little bit, but Planned Parenthood. This is the cost of swapping out for the entire fiscal year, the $1.13 million of federal funds that the HR 1 restriction that began in July, so that we maintain the actual same budget for Planned Parenthood of New England. It's just the cost of the general fund, the federal, that represents that roughly 58% federal share of match dollars in Medicaid for the services that Planned Parenthood provides. And then I've provided just a little bit of a note here, and this should also be familiar to most of the committee members, that our system keeps up with Medicare in terms of our fee schedules. And so we do that in a budget neutral way, but we want to keep them aligned so they don't get out of whack. And so that's happening right now as we go along, but those adjustments are designed to be budget neutral for us. But some providers may be seeing that as we put out what we call our PBRs and our adjustments for them annually. That happens January, and a few of them happen in February. So that's the summary of our programmatic budget for the budget adjustment.
Okay. Let's continue.
Okay. So there are two one-time general fund requests for DIVA, for BAA. Actually, one of them might not be in the BAA language. It might be in the Big Bill language coming a little bit later. But the first one is an IT project. It's the cloud migration for the Vermont Health Connect. And this is we have to stay in compliance by staying up to date with vendor hardware. And as part of doing that, we are moving to cloud supported functionality so that we remain, sounds like a horse almost. So that we remain here. That's right. So that we remain in compliance come January and until the VTIE system can come onto line. So that's the general fund share of that is $2.7 million. It's activity that's happening now to make sure that we are in compliance and that the supported for the Vermont Health Connect. So that's the first one-time item.
Question.
Yeah.
So you're moving it from your own servers, hard drives, whatever, to a cloud-based system. that what you're doing?
So
Sounds like-
I'm not the best one for the IT description, but,
Sounds like it.
But
yes.
Is it merely to comply with the federal data services hub, or is it also any cost effectiveness to it? Any reduced cost by doing it this way as opposed to having your own hardware and software?
To the extent there is, it will be embedded in that estimate of general fund in the analysis. And off the top of my head, I don't remember, but we can look and see if there were offsets in the whole analytics of the cost of the project.
I was curious about all these IT projects, having dealt with them myself in the past, but
It's called an IT ABC form that lays out, the cost of the new and then any offsetting pieces in it. And so this was what nets to the bottom line total of a general fund need.
sometimes in the long run, you may not come out ahead. And so one thing to come out ahead in terms of technology, being able to have higher security and everything. Another question is whether or not the licenses and everything that you have actually end up costing you more money doing it one way than the other.
I know a large chunk of this IT cost is license costs.
Do we have a choice? No, it sounds like we don't have a choice.
We have to stay in compliance.
That alone. Go ahead.
But I'm concerned about this comment that this is to keep it in compliance until we can move it to the E&E program.
Until the VTIES project is able to replace it.
Right.
So that's the whole movement of the system, the eligibility system.
That
We've been an ongoing years.
But will that eligibility system replace this eventually?
There will be a new system. I'm gonna be, the idea is that that system will also be in compliance, and we will, I don't think I can describe what the transition of that system is, but there are people that can to you. Yep.
So it does. It sounds like it's going to maybe migrate back again eventually.
Maybe. E&E's been around for a long time.
And then the last item on here is, we have what's called an alternative payment arrangement with the retreat, where we every year contract for a certain amount of beds at a certain rate under a certain construct. That base amount of bed days that we buy at a flat rate, and the overage corridors that are in that contract allow for, when we utilize more beds than the base, us to pay them. There's a corridor where a certain amount of beds are free for us. The structure of that contract changed last year. We got more beds for a lower rate, but we also moved the overage payment sooner and the free beds a little further out. And so we are on track to the state utilizing the bed days, and based on what we can see in terms of the match needed, most of them are general fund bed days, because when the stays are longer or the stays are forensic, those are paid for with general fund dollars instead of matched Medicaid dollars. And so the contract is for the calendar year. That's why you see it in the budget adjustment. We will go through a full reconciliation of the bed days. We have until, we only have 2 weeks left in the calendar year for the bed days. So we're pretty sure about how many bed days we're using. We have to, get through the reconciliation of exactly which payer, the state, is there another payer? Are they general fund? Are they global commitment fund paid days for the run out of the last few months of the year? But we can see already that we are in that category. We'll have under the contract, the reconciliation payment. And this is the estimated general fund share of it. It's very similar to what we paid last year.
I think it was 11 million last year.
So you actually funded 11 million. In the end, we actually paid them 7.9, but we actually used that differential because we had that problem with our rebate refunds. That was the way to solve that. We were seeing that at the end of the year. And so this number is very similar to the actual reconciliation payment that we made. The year before that, it was $12 million that we paid them.
Great. Any questions on that, Dave?
A different topic, if I may. Does the federal subsidy for healthcare premiums that's being discussed in Congress now, does that impact in any way what our Vermont subsidy is for healthcare premiums? Is it linked in any way?
Yeah, it is. So what you're talking about is the enhanced, and so that came out in the Inflation Reduction Act. And so with those expiring, the subsidies are still there for some individuals. It won't be there for individuals over 400%, but there is still subsidies there. So there's just a lower subsidy amount that
The Vermont amount will be reduced
Yes.
too?
Well, the Vermont Premium Assistance Program, which is
Sure, yeah.
which is what I think you're referring to. The cost of that to the state went down with the enhanced. And so when you see the 27 budget, you will see that we are estimating an increased cost of that program, but the structure of the subsidy is not changing. I don't know if
Okay.
Deputy Commissioner Strumolo is on with us or not.
Able to make that.
Okay, but so we still have that Vermont Premium Assistance subsidy. We expect, because less of the cost is being picked up by the enhanced tax credits, more of the cost will fall on the state to maintain that same subsidy level.
But not a BAA issue?
We're not seeing it as a BAA issue because of the timing of because it's the back half of the year and the timing of when it hits. But you will see, there's a small adjustment up for, in that caseload and utilization number for it, but you'll see a more significant one for the full year in 27. Yeah.
And probably doesn't impact BAA, but we appropriated, I think, 10 million last year for the stabilization fund. Could we-
The next page.
So actually on your website, because I got a notice around 1:00 today that it's been posted on the legislative website because we submitted it yesterday. You did actually ask us for a report on December 15th.
And here we are.
So that the report lists everything, all the applications we've had to date, what we have awarded, what the status is, what's left, what we have not awarded, et cetera. And we are still, today we got another application in. And so based on where we are right now, we have about 3.3 million left from actual awards that have been signed. We have far more than that in pending applications. It's only a handful of applications, but the requests are significantly higher than they were earlier in the year. And so that's the status of the provider stabilization general fund, one-time $10 million currently. And so we are still working through a review of about 5 current applications.
Okay, so it's been posted, is it?
It's probably posted to the legislature's website, so I will find it.
Okay.
I'll send it to-
And you can
That would be
have a
good.
hard copy of mine if you want.
That's okay. We can get it posted on our.
Good.
Yeah.
Okay.
And I don't know if there was anything else the committee wanted to discuss about the provider stabilization.
Trends, what are you seeing?
So we've had applications from several different types of providers, res care, hospitals, FQHCs, one designated agency, primary care practices. And they're all over the board in terms of their situations. We're treating every type of provider the same way. Primarily, we are utilizing the resource we have of the forensic accountant for the larger organizations, the hospitals, the FQHCs, the designated agency, because they're bigger and more complex. And so you'll see in that report, they've been very small to more substantial from the FQHC. This is an editorial comment that might not be welcome, but it's not a solution to everything. It's stopgap in nature in some cases, or time, just a timing bridge. But all different organizations have all different stresses. Some applied, you can see that they're in good shape. They're just seeing if they qualify or. But primarily the bar that we use is whether or not there's real imminent risk and whether or not it's a provider that's very important to Medicaid programs. So, and then we consult with the other departments for res care with Dale, for, the hospitals and the primary care with the healthcare reform team. If it's a nursing home, we put them down the path of because the nursing homes have their own it's an EFR process, which is a matched process if they're there.
And we have a lot of stressed out organizations between provider stabilization and then the nursing home EFRs, which are down from last year, but there's still, $14.5 million is nothing to sneeze at there. So it's clearly a system that we are propping up that could be healthier.
Yeah, and knowing where it's, what the struggle is, what does stabilization look like and mean in what time frame?
Yeah. Right. Wayne?
And so two parts to that. Let's go on that one. So prioritization, you said treat them all the same, but obviously.
We treat the classes of providers the same, but we look at every individual application and in the more complex, larger organizations, we have this resource through the central office of the forensic accountant who we send their application and their supporting document there, and they have conversations with them. They look at them. They share their thoughts on the strength of those stabilization plans.
You are trying to get the biggest bang for the buck.
We're trying to be it's a slightly unusual program of one-time money, and we're trying to be as consistent and aligned with the intent of the legislature and when you granted this appropriation.
So the 5 applications that you might be able to do, how do those match up with the $3.3 million remaining? It's going to eat that all up. Is it more than?
Oh, it's way more than that. It's like $8 to $10 million.
So you're not going to have a problem spending all the money.
No.
But the question is that
Somebody comes here and says we have a problem.
are there critical system of care providers that from now until the start of it,
Yeah.
should we be adjusting the stabilization capacity in the BAA to try to accommodate saving some system critical organizations? We just may not know, but if we do nothing and, the 3 million is gone and there's still some legitimate, wrong word, but legitimate need, what would we do? We wouldn't have an appropriation, right?
I know, and I'm so you actually have to have the conversation too about what does it mean to have a continuing appropriation and your moral hazard and what is the system, different systems, what makes sense, because this is 100% general funded. We're not drawing any match on it. And so, thinking through what that means systematically, I think is something that you want to do.
I thought buying time while a provider is stabilized to do the analysis of what is the future state going to be.
But that's provider by provider. You're talking about it having something that's always there for every provider, because there's always going to be another provider in that situation.
Yeah, not always, but yeah.
Yeah.
Appreciate that. Yeah.
Yeah, didn't we have this conversation the last couple of years, maybe 3 years ago for the Vermont Veterans Home? I mean, this was the whole issue, is that we kept getting these huge requests for BAA that were ongoing continuing costs, and it was like you're creating moral hazard by paying it all on the BAA without.
We don't want to use the Budget Adjustment Act as the budgeting tool.
Right.
So-
We want to use it for a tweak, and the Veterans Home was, for whatever reason, actually being asked to use it as a budgeting tool. And we stopped that. I'm not sure that I would say this is the same thing.
No, but it
I
could.
think there's also what these guys and other departments in human services is have to predict, right? And project what you think utilization will be, who you think is going to be failing or not. And
Well, we don't do that.
And, well, or
We see applications that come in and we try to apply a consistent for each type of provider approach to them, and evaluate them. And, you could, as you go through time, you're using down the balance of this appropriation. But as we see right now, most of the applications came in June and July. It took us a while to get our system of how we did this in, and now we have more applications in as we're spending down this balance. And so that's where you're left, is this question of what does it mean for a one-time appropriation? And what is it, and what does, I don't know what the answer is. But
it's the new money. This is what's left from what we had in the budget last year.
what you appropriated last year,
Right, which is what, 10 million?
10 million.
So you're just running this, is there an agency or department that's actually trying to do the assessment of whether, what we need out there, what it will take to fix the system? Or are we just plugging a hole, throwing some?
I mean, that's a collective effort of everyone in terms of what, we have our rates that we pay for the services that we provide in Medicaid. Not all the stress that these providers are under are Medicaid driven necessarily, the stress across the board in all types of healthcare providers. So all of those have to be weighed. But I'm coming back to the fact that if you were looking for a ongoing base solution, you might want to look at that differently than one-time general fund money.
Right, because those could range anything from poor business practices to legitimate real pressures.
Or even, what is, I mean, it's a market, and being in the position of picking winners and losers is not a comfortable position for anyone.
A happy note.
We'll go to primary care. You also provided significant one-time bridge money for primary care because of the change in the ACO. And we just wanted to let you know the timing of when those payments are scheduled to go out. So we had $10.8 million of global commitment funding to go to primary care and to SASH. About 5 million of it is going to SASH, and the other 5.8 is going out to the primary care providers. And those should be going out either in late January or early February. We're working on the SASH grant agreement right now. The Medicare blueprint one-time payments are all keyed up and will go out. And then you also added general fund funding, $835,000 for the comprehensive payment reform and $3.2 million for additional primary care transition. And those will go out in 2 payments in January and then one in June and July.
And this was, we're dropping the ACO, but we're going to go to AHEAD, except AHEAD is probably behind and not really going to happen. Unless you know anything more about. But that was the plan, right? That we were going to, this was the bridge to AHEAD. We haven't heard anything more about AHEAD at this point.
No, but we do know that we have 6 hospitals that are in the hospital global budget for the calendar year 2026. That's moving forward.
Yeah. Okay. Is that everything or is there more?
Well, that's everything really fiscal
What else would you like to tell us?
If you have other questions.
Do we have other things on our list, Nola? Did we have other things, or were there other things besides the utilization and a couple of other things? You have one more thing? Good.
Well, buy-in, question about buy-in. You had a question about buy-in.
Oh, buy-in. I
Oh.
didn't know what that meant.
Oh, so,
Again.
we buy folks at certain income levels into Medicare. So we pay their Medicare premiums, and co-pays depending on what program they're in. So all duals are basically in buy-in, they're both in Medicare and Medicaid. So Medicare is the first payer of the services, and then we're paying the buy-in and anything that Medicare doesn't cover. And then we also have the Medicare Savings Plan programs, the QIMBY, and the qualifying individual programs, the expansion of that, which is turning on now in January as well.
Mhm.
And so that's that bill it comes as an invoice from the federal government for Medicare. You know, most people get that bill, and if they're on Social Security, it's deducted. But for states, we face the full impact. We're not held to the increase in Social Security the way individuals are. We get the full impact of Medicare financing as a state on the cost of buy-in, and that we have to pay for that when we get the bills from the federal government. So every January, there's an adjustment, up or down. Sometimes we are slightly off with the number. What we're seeing in our accounts, the federal government lags us a little bit in timing, and then it catches up. So
So this is a payment that we have to make, or?
this is a payment that we make on behalf
How much
of.
has it been typically?
So I didn't bring my budget book, but it's a 40-something million line item in gross dollars. Because
And we
the majority of it is
increase-
matched. The majority of it's matched. The qualifying individuals are 100% federally funded. So that's and then a very, very tiny amount of it is in our state only, like 3 invoices, 3 people. It's a very, very small amount. And that's going up to a bigger amount because of the expansion of the MSP program.
We increased the program.
Yeah.
Right,
Yeah.
so this is,
Great.
yes, so what we did a couple of years ago, or
Yes.
whatever it was, or 2 years ago, was we would call it, we use different language that you're using, so I'm thinking of it as the Medicare cliff, or the Medicaid.
It's a Medicare
That's
savings program. It's a
People turned
MSP.
65.
Yeah.
And they've been on Medicaid, and now they have to go to Medicare. And so we put money, we said, well, we'll expand the population who will pay for, right, Dave? And
Yes.
to some percentage, we could only do a little bit, but we did some, and now that's going to start.
And the great thing is it doesn't look at resources. Meaning, it's not like, whoops, you've got more than 2,000 in the bank, you can't, doesn't look at that.
Right, but I think it's related to also to the dual.
Well, the duals are, by nature, a dual is both on. And so
Right.
they're on
Yeah.
Medicaid and they're on Medicare. And so we're paying first for their Medicare coverage, and then we're wrapping around what Medicaid will cover that Medicare does not. And those people are fully Medicaid eligible. It's the qualifying individuals and the qualifying Medicare beneficiary that are the expansion population, and the population where we want to make sure that, because we can match that buy-in. And the qualifying individuals they have a slightly lesser benefit, but it's fully funded by the federal government.
So Dave, you're conversant in buy-ins.
Well, I'm conversant in the Medicare savings program,
Okay.
which is, I guess,
A big chunk of that is buying.
part of it. So,
Okay.
yeah.
Right. I remember hearing about the phrase buy-in in here in the past, but
When it's our shorthand, we buy you into the,
yeah.
actually, the federal government uses it on its invoices.
Here's your buy-in bill.
Yes, exactly. That's exactly. I just signed one the other day. I was like, yes.
All right.
You would.
Okay. Thank you. Thank you, Nolan, for remembering that was one of our questions. Did we get everything on your list? Did we have?
Dave says anything.
No, we're good. Anybody else have other questions for Stephanie and Deshawn? Anything else you want us to know about?
Sure there is. I can't think of it.
Thank you.
Well, we appreciate you coming in very much. This was our last presentation of the day and everybody hung in there. So I appreciate that happened. Committee tomorrow, we are going to start, so we're going to end a little early today, a few minutes. So we appreciate that. Tomorrow we're starting at 9 with judiciary, state's attorneys, taxes. Emily Byrne is going to talk to us about the budget letter we sent out to agencies so that we can start to become conversant in what we're asking them to do. And maybe do it again in January once we have the budget, but we're going to get our first look at that. And then the Criminal Justice Council, and then we'll have corrections and DCF. Oh, we're going to take a bill off our wall and just look at it. We can't vote. We're not officially in session, but S60, the Farm and Forest Security Bill. So we're going to learn about that. My thinking on that, and I've talked to Tom, who's got this agency back, is that we'll probably strip the money out, have usual contingency language, send it back over to the Senate because House Ag made some significant changes, and then any money decisions would be made at the end of the session as part of the committee conference budget. So we'll take that up tomorrow as well, and end with public safety. So we have another full day, but we're jumping around. We've gotten through most of AHS today. We just have a little bit more. So thank you very much.